Okay, well, thank you everyone for joining. I'm sure we'll continue to have more people join. My name's Lou Radonovich. I'm the Deputy Director of the Respiratory Health Division at the National Institute for Occupational Safety and Health, or NIOSH, at the Centers for Disease Control and Prevention. Welcome to our webinar sponsored by the National Occupational Research Agenda at NIOSH, or NORA. This is the healthcare and social assistance sector of NORA. And today we are having a webinar about the use of germicidal ultraviolet use in healthcare settings. We have a number of distinguished guests who will be presenting today. This is going to be recorded, and our intention is to post it widely for public consumption in the near future. We will go through the presentations completely and then take questions at the end, recognizing that a number of folks may need to leave early. We want to make sure that they can see the content, and we will handle as many questions as we can towards the end of the webinar. So with us today are four presenters. Eli Perencevich, who is at the University of Iowa and Iowa City Veterans Affairs Medical Center. He's going to be speaking about surface disinfection and terminal cleaning, the most common use of ultraviolet in healthcare settings. And then the rest of the presentation will be focused on air cleaning, sometimes called air disinfection in the healthcare space. We have Steve Martin, who will be presenting. He is at the National Institute for Occupational Safety and Health, and will share perspectives from CDC and NIOSH, again with an emphasis on air treatment. Ed Nardell from Harvard University will talk about the history of germicidal UV for air treatment and focus on key studies that have been done in healthcare. And then Rick Martinello from Yale University will share perspectives about germicidal UV, including clinical studies and some efforts that happened in the VA about a decade ago. He'll be sharing with us some lessons learned. Next slide, please. Here's our disclaimer. Next slide. So to start, Eli Perencevich is an associate chair for clinical and health services research and professor of internal medicine at the University of Iowa Carver College of Medicine, and the director of the Center for Access and Delivery Research and Evaluation at Iowa City VA Medical Center. He has extensive experience studying the epidemiology and outcomes of hospital-acquired infections using mathematical models, large administrative databases, and multi-center clinical trials. Dr. Perencevich is an international leader in infectious disease, epidemiology, and health services and outcomes research. And most recently, he was named the editor-in-chief of JAMA Network Open. I'll turn it over to you, Eli.
Thanks, Lou. Thanks for the nice introduction. Appreciate everyone's time today, getting to talk about one of my favorite topics. So this is a little bit of a brief journey of how we're analyzing the effectiveness of UVC in the VA healthcare system. I guess next slide. So these are my disclosures. I'm an employee of the Department of Veteran Affairs, and these are my own opinions, not those of the US government. And again, I'm editor-in-chief of JAMA Network Open. Next slide. So UVC disinfection has been used in healthcare in a variety of ways. We're going to be hearing about air disinfection in the next few talks, but I'm going to mostly be talking about surface disinfection. And this is a supplement to existing cleaning protocols. So typically when a patient's discharged, the cleaning staff, the environmental services staff will come in and manually clean with disinfectants. And then in certain situations, we'll have what we call UV robots put in the room and expose the room with the door closed to UVC. for a certain amount of time, 15 minutes or so. There are many issues with this mechanism for cleaning. It's very hard to study for the list of reasons I put here. When this has been studied, there are varying doses, distances from the surfaces you want to clean. There's an impact of humidity, temperature, and exposure time. And I'll have a slide about this in a minute, but to study this in healthcare settings, you need a really large number of hospitals. So we have very little data on the actual efficacy or effectiveness of these systems. There are a lot of barriers to implementing these in hospital settings, including takes a lot of time to put these in the room and then wait 15 to 20 minutes. As you've probably been, if you've been in a healthcare facility anytime recently, you know they're always full. So if you delay putting in a patient in a room for a half hour to do extra cleaning, it can really impact the flow of patients in your hospital. And then there are some concerns as far as healthcare worker and patient safety, exposure to the skin and eyes, and potentially ozone release, which is toxic. Next slide. So many of the studies, because it's actually hard to study these clinically, and by clinically I mean if you implement these systems in your hospital, do you prevent healthcare acquired infections? They've been studied kind of with intermediate outcomes. So can you show in a lab setting or in a clinical setting that exposure to the UVC light decreases the amount of bacteria, the concentration of bacteria on surfaces? And this is a nice systematic review from 7 or 8 years ago by David Weber. And based on various pathogens, these are all gram-positive pathogens, methicillin-resistant Staph aureus, vancomycin-resistant Enterococcus, and C. diff, bacteria that causes antibiotic-associated diarrhea. There was 1 to 2 log reduction when UVC was applied to these pathogens. Next slide. However, there's very little data in the literature on gram-negatives. We are particularly concerned with the rise of resistance among E. coli and Pseudomonas and Klebsiella. So gram-negative bacteria that are spreading, they cause urinary tract infections and sepsis. And so does UVC work? Because there was very little data in the literature, we studied this at the Iowa City VA. And just briefly, we placed plates in the room and then moved the UVC to a couple locations in the room and then in the bathroom as well, and tested to see the log reduction in these 5 high touch areas marked by the stars. Next slide. And just to kind of cut to the chase, similar to what David Weber showed with the gram-positive bacteria, across all pathogens, there was a 2 to 3 log reduction in the growth of the bacteria on plates in the room. So it doesn't prove that it prevents these infections, but at least it has biologic plausibility to prevent infections from spreading in hospitals. Next slide. So again, these are in vitro results, and one of my favorite comics, XKCD, Randall Munroe, had this comic: when you see a claim that a common drug or vitamin kills cancer cells in a petri dish, keep in mind, so does a handgun. And that's similar to here. Just because it works on a petri dish doesn't mean it will work to prevent patient infections. Next slide. So I guess if there's one take-home point from my entire presentation, I want you to look up this paper by Natalie Blanco in JAMA Network Open, published before I was an editor, but I guess I'm still biased in that regard. But I think it's one of the most important papers to understand when we're trying to study preventing spread of infections in our hospitals. And this is because it's a way to show how much power we need, how large of a study do we need, how many hospitals we would need to have in our clinical trial to prove that an infection control intervention works. So this could be hand hygiene, this could be wearing gloves, this could be standard disinfection or UV disinfection. And this simple mathematical study showed that if we wanted to show a 10% reduction of Clostridium difficile or 10% reduction of vancomycin-resistant enterococcus in a clinical trial, we would need 300 to 400 hospitals in the trial. And if we wanted to show a larger reduction, so it's easier to show a larger reduction of 30% in either pathogen, we would need 30 to 40 hospitals in a randomized trial. So if we want to study any of these interventions in healthcare, we're going to need a large clinical trial. These are expensive. And so it suggests we need a big healthcare system to more easily study these trials. And I think this is why the VA is really attractive. Next slide. So I wanted to show the typical type of study published looking at UVC, but it's similar for many interventions in infection control. This is a 6-hospital study. They basically implemented UVC and looked at infection rates before they put the UVC robots in the rooms and after. These are called pre-post studies. And their main outcome was acquisition or infection by these pathogens listed here, 5 pathogens, by patients exposed to a room that a prior patient was admitted to with that pathogen. So this is not a cluster randomized trial. It ignores transmission. Next slide. But what they did show overall, there was no benefit. In fact, it looks like putting UVC harmed the patients, which kind of begs biologic plausibility. But in this non-randomized trial, there was an increase, or you probably safe to say there was no benefit from UVC. But again, this was 6 hospitals only, so very far under what my sample size paper that I highlighted showed we needed, and it was mostly driven by an increase in vancomycin-resistant enterococcus. Next slide. So that's this basic state of the literature, and we wanted to utilize the power of the VA healthcare system to see if we could detect a benefit in our hospitals. Over the past 15 years or so, the VA has implemented UVC systems in some of their hospitals, but not others. And so we looked at almost a decade of data in 120 VA hospitals, and we looked at the hospital onset gram-negative infections, E. coli, Klebsiella, Pseudomonas. And interestingly, 40 hospitals had implemented the systems and 80 hadn't. So we had a kind of a natural control group of 80 hospitals. Next slide. And what you'll see is there was almost a 20% reduction of hospital onset gram-negative bloodstream infections and over a 30% reduction in non-fermenting gram-negatives. These are the ones that live in the environment, like Pseudomonas. They're very hard to kill. And so a pretty large benefit, but one that we could detect with the sample size calculations I showed in that earlier paper. Next slide. And just to kind of show how this is, these are the 40 hospitals that implemented the systems. And you can see most were below that one line, the dashed line, and all of those had a benefit, and only a couple didn't have a benefit. But overall, this is kind of variation you see in any large study. Most hospitals had a benefit. Next slide. So because of this variation, we actually did an implementation study where we interviewed 22 hospitals, employees at 22 hospitals, and completed 34 interviews. And the main barriers that we identified when talking to healthcare workers, and again, this is always an issue when you implement something in hospitals, doesn't always work because you have to implement them correctly and try to understand that. So the main issues were distrust of the manufacturer claims regarding the exposure time and overall efficacy. VA hospitals wanted to see VA-specific data, which is why we provided the data I just showed you. There was a perceived lack of UVC's impact on their local infection rates. And there was a lot of concern, as I mentioned, with fast turnover time and staffing. So the hospitals didn't have the staff or time to implement the systems. Next slide. So that's it for my quick presentation. Happy to take questions either now or later. Thank you.
Thanks, Eli. And again, we'll continue on through the presentations. As we do, please put your questions in the chat. There'll be opportunity at the end to handle as many questions as possible. We're going to go ahead and move right along. Next presentation is from Captain Steve Martin, who's a Senior Research Engineer Officer in the commissioned Corps of the U.S. Public Health Service, assigned to the Respiratory Health Division at NIOSH. He has worked extensively on infectious disease outbreak investigations and prevention studies in a range of workplaces, and he's one of 2 NIOSH engineers responsible for most of CDC's ventilation guidance during the COVID-19 pandemic. He led the filtration and disinfection team of the ASHRAE Epidemic Task Force that was formed early in the pandemic and led the Air Cleaning Working Group on the development of ASHRAE Standard 241, Control of Infectious Aerosols. And he was recently awarded Federal Engineer of the Year by the U.S. Public Health Service. I'll turn it over to you, Steve.
Okay, thanks for the introduction, Lou. We'll just jump right in on the next slide. So really what I've been asked to do here today is just to give you sort of CDC's historic perspective on the use of UVGI, so you'll know where we came from and where we stand currently. So the first record of CDC, including ultraviolet technologies in one of their guidance documents, came in the 1990 version of the guidelines for preventing the transmission of tuberculosis in healthcare settings. And really all it says was that once infectious droplet nuclei have been released into the room air, they can be removed or killed with germicidal ultraviolet radiation in the 100 to 200 nanometer range. So just a real quick mention of the technology in 1990. If we move forward to the next slide, the recommendation and the verbiage was expanded a little bit in our 1994 version of the same document. There we say that UVGI lamps may be used as an adjunct to ventilation for reducing the concentration of infectious droplet nuclei. We also mentioned that UV systems can be installed in duct. So this really established our support for UV systems in upper room and in duct, and that's largely where CDC's stance remains today as we move forward. Next slide. We also mentioned UV in our 2008 version, which has been updated a few times, of the guidelines for environmental infection control in healthcare facilities. Again, we talk about using UV as a supplemental air cleaning technology. Here we get specific and mention the use of low pressure mercury vapor lamps, which wasn't a stretch. Those are the lamps that output UV at 254 nanometers. And at the time this document came out, that was really the only option for commercially viable UV systems. We also, in this version of in this document, sort of allude to the impact of equivalent air exchanges from UV systems, and I'm sure you'll hear more about that term as we move on. But this equivalent air change rate is one way that UV systems are being described today. Next slide. So we went from 1994 to our 2005 version of the guidelines for prevention or preventing the transmission of mycobacterium tuberculosis in healthcare settings. Our UV recommendation has largely remained unchanged. This is the current version of our TB guidelines that is out today. So we haven't released a version since 2005. So as I mentioned before, our recommendations on the use of UV technologies really hasn't changed much since we originally mentioned them in the 1994 version. Next slide. Here a little bit different. It goes to the first presentation by Dr. Princevic. In our 2008 version of the guidelines for disinfection and sanitation in healthcare facilities, we do mention the use of UV for surface disinfection, and we make it clear that the use of UV technologies is limited to the destruction of airborne organisms or inactivation of microorganisms on surfaces. We get into there's a lot of research done historically looking at UV for surgical site infections and this type of thing. We sort of downplayed those results in this document, but we do let it be known that we support the use of UV for surface disinfection in healthcare. So you'll notice that all of these guidance documents where UV has been mentioned historically by CDC are directly related to healthcare spaces. But if we move on to the next slide, and this one again is specific to healthcare. This was our guidance for the design, installation, and operation of upper room UV systems to prevent the spread of tuberculosis in healthcare. And this is where we really made a recommendation on the amount of UV required for effective systems in healthcare spaces to control MTB. So I'm not going to bore you with the numbers, but this was a step forward. It was based on some work that Shelley Miller from the University of Colorado did back in the day. It was really a step forward because it was sort of the first time we've gotten away from rules of thumb on system design and operation based on electrical input to the UV lamp. And we got a design guidance based on useful UVC output from the lamp. And this is still current today. This is still used as the de facto design standard by many UV manufacturers today, both in the United States and around the world. And as you're going to hear today, there are new UV dosing requirements that are coming out, and ASHRAE is currently working on a design operations standard themselves. So there's a chance that this document will be replaced with that document when it becomes available. But as it stands today, this is still the sort of the de facto standard in the US. Next slide. So that brings us from 2009 to 2023. Really nothing has changed except that the CDC recommendations has sort of morphed from healthcare only to use them anywhere in any indoor space to protect building occupants from aerosols that are that transmit diseases. So during COVID-19, during our most recent update to our ventilation in buildings page, we had two documents here that we've updated. One is ventilation in buildings. That's our sort of catch-all document where all the technical information is, and we released a new improving ventilation in buildings, which is sort of a plain language version of our guidance. And you can look at both of those there. I won't go into a whole lot of details other than to tell you where we stand with UV if we go to the next slide. So one of the things we did was updated our discussion on UV. The industry is trying to get away from the historic term ultraviolet germicidal irradiation, or UVGI, and going to a newer term, GUV, or germicidal ultraviolet. They're both the same thing, and we're just sort of in a transition phase here. And we readily make it known that CDC supports UVGI as a supplemental treatment to inactivate airborne viruses such as SARS-CoV-2. It may not be useful in all spaces, but it can certainly help in some, and it's also helpful when options for increasing room ventilation and filtration beyond code minimum requirements are limited. Next slide. So on our building and ventilation page, we have two FAQs, FAQ number 6 and 7, that specifically discuss GUV technologies. So I encourage you to go see those. We make it clear that CDC supports, as we did starting in 1990 and 1994, the use of 254 nanometer upper room and in-duct GUV systems. You're going to hear a little bit more today about a new technology that the industry calls far UV. These systems emit UV at a lower wavelength, down around 222 nanometers. They are showing a lot of promise, but right now we still treat them as an emerging technology, and we address all of our emerging technologies in FAQ 6 on our ventilations and building page. Next slide. That's all I have. There's my contact information. If you have questions, I'm happy to answer them at the end of the presentation, or don't hesitate to send me an email. Thanks.
Thanks so much, Steve. That was terrific. We will ask you to continue using the chat for the time being. And again, we'll come back and take questions for all the presenters after they're all finished. Our next presenter is Ed Nardell, who is a physician at Brigham and Women's Hospital and associate professor in the Departments of Medicine, Environmental Health, and Immunology and Infectious Diseases at Harvard Medical School. Dr. Nardell is the prominent researcher of multi-drug resistant tuberculosis with particular focus on airborne TB transmission and control, including multi-drug resistant TB. In addition to receiving funding from NIOSH, he is also involved in a 5-year Fogarty Innovation Grant that uses new technological approaches to airborne infection control to train architects, engineers, and physicians in air disinfection research in Peru, South Africa, and other high-burden countries. He's an eminent scholar on the science of germicidal UV applications, and he's actively developing more efficient and inexpensive ultraviolet germicidal irradiation fixtures. Thanks for joining, Dr. Nardell. I'll turn it over to you.
There we go. I've been asked to talk about the history of germicidal UV, and in particular, some of the key studies, many of which involve healthcare settings, some of which have been in other settings like schools, but nonetheless. Next slide, please. So in way of disclosures, during the pandemic, I was quite willing to help companies trying to develop germicidal UV technologies with technical advice that by and large has ended. I still serve on a scientific advisory board for one of the companies developing 222 UV. Next slide. The idea of hospitals as sources of infection is not new, and I won't delay this or detail this, but certainly in the Middle Ages and beyond, hospitals were horrible places to be, where people were dying and where a lot of disease was spread, and that continues in terms of nosocomial infections. But there has been progress. Next slide. In fact, Florence Nightingale gets a lot of the credit for working in hospitals in the 1800s and noticing their horrible situation and really turning British hospitals, including those that were wartime hospitals, into pristine places. Also with determining from an architectural point of view how much space and how much window to area volume should be, and she literally wrote the book on hospital design at that time. Next slide. And in terms of tuberculosis, under non-COVID times, still the most lethal and cause of more adult deaths from an infectious disease than any other. Most patients with HIV around the world die of tuberculosis, not of HIV per se. And so when you consider that most TB, most airborne infections, are transmitted indoors, it becomes the most important building-associated illness. Next slide. In Russia, for example, where I worked with Partners in Health, we showed and published that patients essentially entered the hospital with drug-susceptible TB and were the biggest risk for getting multi-drug resistant TB was being hospitalized. And if you weren't hospitalized and therefore exposed to patients with unsuspected MDR TB, multi-drug resistant TB, you would not likely get it. Likewise, in South Africa, when in 2006, when XDR TB, extensively drug-resistant TB, was recognized, it was hospital-based transmission that outbreaks that really called it to our attention. Next slide. In Peru, this is just a little observational study from a medical school in Gaetano Heredia in Lima. Students were sent either to one hospital or to another hospital for training. And depending on which hospital they were sent to, a more modern hospital with small windows and more modern design, if you will, the rate of infection was actually twice that for medical students during their time of training. compared to an older style, French style hospital with big windows in that very climate-friendly environment. Next slide. So environment matters. For about 10 years at Harvard, we had a mostly USAID funded course for architects and engineers where we actually taught, Paul Jensen was very involved in this course as well. We taught architects and engineers how to build hospitals that were naturally ventilated and how to use germicidal UV and air filtration. And on pictured here are a hospital in Karachi, Pakistan that was built after the course, and also one in Butaro, Rwanda, by Partners in Health, using the principles that we taught in this course. Next slide. Now, ventilation is great, and in many parts of the world is the most fundamental way of controlling air, of achieving air disinfection, but it has its limitations. And in way back in, I think this is 2009, rather 1989 or 1990, 91 actually, we just showed that, in principle, the effectiveness of air changes depends on how the source strength. Essentially, you're removing airborne particles and at some rate that is relative to the amount of them being introduced. And there becomes a point where you can't keep up, essentially. And the point of this point is that you need an awful lot of ventilation for airborne infection control. It's very difficult to do that with room air cleaners. It's difficult to do that with HVAC systems that are designed for comfort. And when we consider so-called super spreaders, and in particular, one needs an awful lot of ventilation or equivalent ventilation to achieve the kind of protection that we would like. And so this paper on the theoretical limits of air by building ventilation, we published quite a while ago. Next slide. Now, Paul Jensen, former CDC, NIOSH also, did the study with Grigory Verchenkov in Vladimir, where they had a room in a hospital that was being renovated and compared using aerosolized bacteria and quantitative culture the effectiveness of mechanical ventilation and 3 air cleaners, as well as upper room UV. And the upper room UV, as you see pictured here, were locally made fixtures, nothing very sophisticated, but effective. And you see that even using these relatively simple fixtures and inexpensive fixtures, that the most cost-effective approach to air disinfection was upper room germicidal UV. And it's simply because you're disinfecting such a large volume of air at once. Anything that requires you moving air through a box or through a ventilation system is inherently less efficient because of the need to move that air at high volumes. Whereas in-room air disinfection, moreover, if you're talking about person-to-person transmission, the air disinfection must be in the room where the source and the potential victims are. Next slide. There's another limitation of ventilation on the horizon and actually happening, and that has to do with global warming. If you look at India and Indonesia and many parts of the world that have depended on natural ventilation, you find that there is a skyrocketing use of air conditioning, oftentimes split system air conditioning. And with that, you get an immediate need to close the windows and an immediate increase in the shared air fraction, which is to say an increase in risk of airborne infection. Next slide shows you a little study we did, just a demonstration really, in an office in South Africa, where we had closed a window with 5 people in the room and measured the CO2 rise with a split system air conditioning on. And of course, all the air conditioner was doing was moving the air in the room. But you see a steep rise within an hour. You had doubling of the CO2 rate. That is a significant increase in risk. You need to replace that air disinfection, and the only practical way to do that is germicidal UV. Air cleaners could do it, except for the difficulty of moving enough air with acceptable noise and and efficiency. Next slide. Now, germicidal UV isn't new. This is a 1946 text by GE lighting engineer Matthew Lukash, wrote many books on lighting, and including this one. And if you go through this book, the technology is basically spelled out in detail. So in the 40s, germicidal UV was already in use, and the study that I'll show you from schools in the 30s, we already knew that it worked quite well, even against something as infectious as measles. Next slide. So there'll be several types of studies that I'll be referring to. One of them are chamber studies, and they're the most common. They're sort of easiest to do in the laboratory, very small chambers, which are necessary for determining the susceptibility of specific pathogens, the so-called K value or Z value. Large room studies, which incorporate air movement and are sometimes useful for establishing an effect size and maybe even to get a sense of what kind of doses you would need. The ultimate, of course, is an epidemiologic study. We have very few of those, and they're difficult to do. We'll hear more about that from Rick later. And then we have human to animal transmission studies, and there's been two of these in particular. Rod Escom in Peru did one, and we did one in South Africa using the Wells-Riley human to guinea pig transmission model in a real hospital. Both of them were in real hospitals. The guinea pigs only serve the purpose as exquisitely sensitive measures of tuberculosis in the air. We can't measure TB in the air by other air sampling methods. It's not an animal study. It's a human study using animals as a quantitative air sampler, hundreds of them. And then finally, I'll mention, if I get enough time, to mention a UV dose monitoring study, which tells us something for about 222 in particular, not only about safety, but about potential efficacy under real life conditions. Next slide. So this is a simple room study conducted by Richard Riley in his office in Baltimore. And the line in that graph shows the gradual decline in culturable BCG bacteria, which are surrogate for TB. And then you turn on one simple 30-watt, 15-watt lamp in that 17-watt lamp in that room, and you see the accelerated decrease in culturable bacteria. And actually, this very study was used as a guide to dosing for many, many years. And as Steve mentioned, it did not take into account the output of the fixture. It told us we had a 17-watt fixture. And it was argued that if 17 watt gave us the equivalent of 12 air changes, 30 watts might give us something like 20 air changes, and that would be a good thing. And that's basically what was done. And the square footage of that office was about 200 square feet. And that's what we had for many years, this rule of thumb. We've gone beyond that. Next slide. This is a more modern room study using 222 far UV, which can be shown directly into the room. And you see this illustration of 1, 2, 3, or 5 fixtures in a chamber, room-sized chamber. And Staph aureus was used as a convenient test organism. And you see the almost instantaneous disappearance of organisms coming out of that room, a ventilated room, with the 222 germicidal UV. Next slide. Now, this was our chamber at Harvard School of Public Health on top of a roof. And in the right upper panel, we see a ball in the middle of the room where organisms were aerosolized. And you see some UV fixtures on a shelf. And we did many, many studies in this room with an air mixing fan, determining Z values and also efficacy and dosing strategies. Next slide. Now, I wanted to refer to these 2009 guidelines that Steve also mentioned, and this was Shelley Miller's work done in a chamber. And she came up with 2 dosing recommendations, 30 to 50 microwatts average irradiance in the room, which is indeed a usable UV flux recommendation. And then she also said 6.3 watts total UV lamp wattage. So this did not take into account the efficiency of the fixture. And like Riley's study was not that useful because fixtures we have found out, vary greatly in terms of their efficiency. But the 30 to 50 microwatts is a useful number. The problem is, how do you predict 30 to 50 microwatts in the middle of a room before you put the fixtures up and do the measurements? So we'll see that there are more, I think, useful guidance that came out of our South African study that are being used by the ASHRAE guidance that is about to be published soon. Next slide. So in terms of epidemiologic study, this is sort of like the gold standard. And you see on the left-hand panel an actual classroom in Germantown or Swarthmore, Pennsylvania, where William Firth Wells and his wife Mildred, importantly, his wife Mildred, did this very detailed study of respiratory illness in children, the upper classes being the controls, the lower classes, and they didn't mix much between the upper and lower classes, being the irradiated classes. And you see UV fixtures above the ceiling. Now, fortunately, in the 1930s, ceiling were very high, and they were able to probably have very effective systems in these classrooms. Next slide. This is the results of that study. It shows the upper classes in the lower panel with week by week with numbers of measles cases. Now, the upper classes were less vulnerable to germicidal UV because they had been exposed, presumably in the past, some of them, where the younger classes were more vulnerable. And you see the dramatic reduction in the classes that were irradiated among the younger children who were getting much less measles despite the fact that they were more vulnerable. Next slide. Now, another experiment of nature, if you will, in a hospital that put up germicidal UV to protect healthcare workers against tuberculosis happened to have an influenza outbreak in 1957 and 1958. And those wards with UV, the TB wards, had 90% less influenza than comparable wards where there was no germicidal UV. Now, this was not a pre-planned placebo-controlled study, but it is a remarkable demonstration of efficacy against viral infection, in my opinion. Next slide, please. So in the late 90s and into 2000, Phil Brickner, Richard Vincent, myself were involved in a large tuberculosis shelter study in tuberculosis shelters around the country. George Comstock was an epidemiologist, was our epidemiologist, and these were placebo-controlled. And unfortunately, by the time this study was mounted, we had too little transmission to really demonstrate efficacy. We did, however, demonstrate safety in the sense that we administered questionnaires to the staff of these shelters, and they didn't know whether they had real UV or placebo UV. Fixtures that looked like UV were putting out no UV, and there was essentially no difference in the number of complaints. Next slide. This is the study in a human to animal study by Rod Eskom in South Africa. Humans in a TB ward exposing guinea pigs in a chamber, and it showed UV efficacy of 72%, adjusted as we do for air sampling for multiple hits. This is about 80% efficacy. Next slide. We did a similar study in South Africa where, again, patients in 6 beds, the air from those wards went to guinea pigs on every other day. And on the days when the UV was on, one guinea pig chamber was exposed. The days UV was off, another guinea pig chamber was exposed. And we showed, next slide, this is the data. At the end of the day, there were 15 infections, and actually was more than that. This seems to have gotten a little off kilter, but with the numbers being distorted a little bit here, there was 80% protection, almost identical to what Rod Eskom showed under real world conditions. These are real patients generating human aerosol, not artificial aerosol, not using culture as an endpoint, but using real infections as an endpoint. And this was the equivalent of adding 24 equivalent air changes. The data from this, in terms of how much UV we used, has been used as the basis for current guidelines. We recommended 17 milliwatts per of total fixture output per cubic meter. We've now down, based on another experiment, which we haven't published, down to 12 milliwatts of UV total output per cubic meter of room volume. Next slide. And this is the paper that demonstrates those results. Next slide. 2009 guidelines I mentioned. I mentioned this again, only that I think these fixture output guidelines are easier to implement. We can say we have so many cubic meters, we need so many milliwatts of total fixture output per cubic meter. The other big factor is ray length, because if the longer rays are able to travel, the more volume they disinfect. If they have a very short run, they're less effective. Next slide. The other kind of study which I would like to mention is particularly for far UV. The upper panel shows a nightclub in Boston where there are 6, you only see 4 UV fixtures in the ceiling that are shining 222 UV directly into the room. And below, in a Columbia dental clinic, same idea with 222 whole room UV. We've used shoulder-mounted photographic film that is sensitive to 222 to measure the dose that people sitting in the room, waiters walking around, dental staff walking around, the dose they get in the shoulder level is the breathing zone, tells us something about efficacy if we know the susceptibility of a virus in that breathing zone, and also safety in terms of the head and neck, which is the most exposed part of the body. These studies are very easy to do and give you real world safety and efficacy estimates, and are much better than using arbitrary point source eye level measurements suggesting that something is dangerous. That is my last slide, and I will stop there.
Dr. Nardell, thank you so much. That was fascinating. So our final presenter for today is Dr. Richard Martinello, who is a professor of internal medicine and pediatrics at the Yale School of Medicine. He's board certified in adult and pediatric infectious diseases. Dr. Martinello serves as the Senior Physician Director of Infection Prevention for Yale New Haven Hospital and the Yale New Haven Health System. He leads teams focused on developing programs, policies, and processes to prevent healthcare-associated infections, and leads an active research program and is funded by the CDC for work focused on improving infection prevention and control. Dr. Martinello is a member of the board of directors of the International Ultraviolet Association and a co-chair of the IUVA Healthcare Working Group. I'll turn it over to you, Rick.
All right, thank you very much, Lou, and thank you to the organizers for having me speak today. Next slide, please. These are my disclosures, some of which were already mentioned. I do have a research contract also with Mina Technologies focused on assessing far UV in the healthcare setting, and then I serve as an advisor to XCMR. Next slide, please. All right, so what I'm going to talk about is a study that we had set up to perform back about 10 to 15 years ago. And what we were very interested in investigating was trying to better understand how influenza was transmitted person to person, and more specifically, how much of influenza transmission was attributable to fine particle aerosols between persons. What you see in the figure on the right-hand side is a figure that was from the most recent WHO publication, looking at updating the terminology we use when we think about pathogen transmission through the air. And you can see that we could think about these respiratory aerosols transmitting infections between persons in a multitude of different ways. In the past, we talked a lot about larger droplets that followed a semi-ballistic pattern and were able to not only contaminate surfaces, but also could expose somebody more directly. But then also we thought about particle aerosols that could contaminate somebody who was in that near field area, but also could stay, those fine particle aerosols could remain infectious and aloft in air within a space for a more prolonged period of time and potentially infect somebody at a distance or somebody who enters the room at a later time, and that infectious aerosol was still present in the room. So we were very interested in better understanding how influenza was transmitted. Next slide, please. So with a great deal of discussion on how to approach this, what we settled upon was focusing on nursing homes that had expertise in caring for patients who had severe dementia. And the reason this was a very attractive setting for us was patients with severe dementia are typically cared for within locked nursing homes. And while they have staff that are coming in, of course, from the community who may bring influenza in with them, they can have visitors that can come in from the community and may also introduce influenza into that area. These patients otherwise remain on their locked unit, and they do interact with each other within that very residential setting, but they remain in that locked unit. The nursing facilities that we were investigating were further attractive because in the wintertime, when, of course, most flu is transmitted, the patients stayed on the units. The dementia was typically so severe that they were unable to go out into the community in a supervised manner. They stayed in their areas. And so we found that to be very attractive because we knew that if those residents of that nursing unit acquired influenza, we could be very confident that they acquired it on that unit. So the design of the study that we proposed was a double-blind, cluster randomized crossover study. And our intervention was going to be upper room germicidal UV. And we would have half of our units set up with sham bulbs that looked just like low pressure mercury bulbs within the fixtures. And then the other half would be with active germicidal UV low pressure mercury lamps. And so the unit of randomization would be the unit itself. So we would have one unit with active upper room germicidal UV, and the other half of the units would be with those sham bulbs. The outcomes that we were interested in was identifying patients who developed influenza-like illnesses, and then performing laboratory investigations to determine if, in fact, they were infected with influenza itself. Our analysis would be using a generalized linear mixed model to control for any potential confounders. Next slide. So the questions that we really wanted to answer through this study was, first and foremost, how is influenza transmitted from person to person? And if fine particle aerosols were playing a role, what fraction of transmission were identified due to that aerosol transmission between persons? And we are further interested in better understanding what controls could be implemented to decrease transmission of influenza virus between individuals. And the hypothesis that we chose was that 75% of influenza transmission would be due to exposure to infectious fine particle aerosols. Next slide, please. So we decided to perform this project over a 5-year period, and annually between the months of November and May, we would perform surveillance to identify patients with influenza-like illnesses. And that active surveillance would consist of having a staff nurse round twice daily talking with other nurses on staff to identify any patient who had developed an influenza like illness, meeting our case definition. When we would identify an individual patient who had an influenza-like illness, they would undergo a structured interview and a review of their medical records to determine what their potential exposures may have been and what their behaviors were like. We would perform laboratory testing on that individual to determine if they had influenza, then of course using a nasopharyngeal specimen. We had considered doing serologic testing at the beginning and the end of each season, but ultimately decided against that. Next slide, please. So the inspiration for our study, as you heard from Dr. Nardell, was a study that was performed during 1957 to 1958 at the VA in Livermore, California. This VA was focused on the care of patients who had tuberculosis. And what we had heard from Dr. Nardell was that of the two buildings where patients were housed on this campus, one of the buildings was had upper room germicidal UV lights installed. And when the influenza pandemic of 1957 to 58 occurred, they had found that the attack rate of influenza based on serologic testing was about 90% less in the GUV treated building compared with the building that did not have any upper room germicidal UV. And so we had really intended to replicate this study with using more modern methods. Next slide, please. So these are the blueprints of the building where we primarily sought to perform this study. There were 2 floors where patients were located, and each floor contained 2 units. So 4 units of patients altogether. Next slide, please. And the left-hand panel of this slide shows the work that was done to install upper room germicidal UV devices. Those are shown by the blue rectangles. And we also installed a number of fans on ceilings and on walls to ensure that there was appropriate air mixing. And those are shown in the yellow circles. We did install these devices throughout the entire building. I just marked up the left hand side of this slide just to illustrate that we had extensively treated the building. We did work with an architectural and an engineering firm with expertise in germicidal UV to determine where the lamps would be located and where our mixing fans would be located. And then we also consulted with other experts such as Dr. Nardell himself, and also with Dr. Shelley Miller to ensure that we had a sufficient amount of treatment throughout these spaces. Next slide, please. Some strengths we felt of this study were the random cluster design using the sham bulbs and the active bulbs, and then we had planned to have an annual crossover. We did our sample size estimations estimating that we would have about a 3.7% attack rate on an annual basis. And that was based upon an older study by Drinka et al. That was published in 2003, which looked at about a 10-year period through mostly the 1990s in a nursing home setting, and reported on about 3.7% of the residents of those nursing homes developing influenza on an annual basis. Some of the other strengths that we had identified was that using a locked inpatient long-term care facility allowed us the ability to better understand how those patient residents were potentially mixing with each other. But also the fact that they stayed within that unit was very useful from an epidemiological perspective. We had planned on a 5-year study to obtain sufficient power. And you can see that our study was powered about 86% to detect a 75% attributable rate of influenza transmission by fine particle aerosols. We had also planned to develop a biorepository that was going to be linked with demographic and clinical data, and subsequently attempt to obtain funding to perform molecular studies on our biorepository to better assess how the flu virus was transmitted from patients to other patients. There were a number of limitations to the study, some of which I already mentioned. I think that the largest limitation that we experienced was the power of our study. And even though in our relatively small area, we planned a 5-year investigation, we really needed to have a large number of patients developing influenza during that 5-year period for us to attain that sufficient power. From the time that Drinka published that estimate of about a 3.7% attack rate in his nursing facilities, a few things came about. One was the availability of antivirals that were more highly active against influenza virus itself. And then the second change that had occurred over time was that there was a great deal of change in the philosophy on how patients in nursing facilities should be cared for. Transitioning from more aggressive care consistent with inpatient acute care hospitals to that of taking a more cautious approach and thinking about futility in some of the testing and the treatments that were performed for this very frail patient population. And so what we saw with that was the attending providers for these patients really moving away from doing a lot of testing to being very cautious about how they tested their patients and about how they applied treatments for their patient. One exception to that, which was very important to note, was that when we had started developing the protocol for our study, only about 10 to 20% or so of that patient population in that nursing facility routinely were vaccinated each year against influenza. By the time we had launched our study, there's about 100% of those nursing facility residents who were routinely becoming vaccinated against influenza, and that no doubt affected the power of our study. Next slide, please. So when we were installing the upper room UV devices, we did find a number of physical constraints. This was an older building where we had performed this study. The hallways were very long and very narrow, and the ceilings were low. But also we had a great deal of heterogeneity among the different types of rooms, and there were some very large common rooms that also needed to be treated. As I had mentioned, we worked with an architectural and an engineering firm to ensure that we had a sufficient amount of UV irradiance within the space. Something else that we did was we wanted to ensure that the patients and the staff who were working in the area would not exceed the threshold limit value for ultraviolet light during any single shift. And so we worked very hard to make sure that that was the case. We had an expert in the use of UV who was very involved with metering each of these different spaces and making sure that we would remain under the threshold limit value. And then also throughout the time that the lights were on in this space, they were rounding there on a weekly basis to ensure that all of the devices were not exceeding those TLVs. Something that we had done that I think was relatively unique was, and to ensure that we stayed under those threshold limit values, was we had rheostats installed on all of the luminaires so that we can make some fine adjustments to the amount of UV that was being produced by each of those lamps. On the left-hand panel, you can see just one corridor reflecting some of those physical constraints that we had, but also in the upper part of that room, you see two of the luminaires, and on the upper left-hand side of that figure, you also see one of the lamps that was installed to circulate air. One final safety intervention that we made that I'll note is that we also installed an infrared curtain, if you will. And this was an infrared lockout device that if somebody, let's say if we had a patient or a staff member that stood up on a chair and put themselves into the upper portion of the room, that infrared beam would be broken and it would shut down the lamps in that area. And the lamps were then sustained in an off position for a period of time until we thought it was likely safe to have them turned back on again. Next slide, please. Some of the safety features otherwise, and keep in mind that this was in a nursing facility that was specialized in the care of patients suffering from dementia. We did put tamper-proof screws in all of the luminaires to make sure that if somebody did have a screwdriver, that they could not get into these devices and potentially expose themselves. We did put special key safety switches in all of the areas. So when our facilities team went in, they were able to shut down all of the devices in an area if they needed to work in the upper part of the room. And then in some areas where our fans were lower within the rooms, if they were under 7 feet in height, we did have guards on those fans to ensure that if individuals put their hands up in that area, that they would not be injured by the blades of the fan. Next slide, please. We did come across a number of challenges among our staff, and then also patients and concerns raised by the family members of those patients. We did have and find that there was a number of misunderstandings of germicidal UV technology, and some individuals did raise concern for cancer, and then also concern for potential injury to their eyes. Something that was most helpful for us was trying as best we could to get out in front of that and really introduce the staff and the family members of the patients in this space to UV light as we were getting ready to initiate the trial. And that helped them to understand what was going on. Unfortunately, we did still find it very difficult to allay everybody's concerns. And in one instance, we had an eye doctor who still felt that UVC may be injurious to their patient who is a staff member working in that area. We worked very closely with the Human Investigations Committee at the facility. We did receive a waiver of informed consent, but because it was a randomized intervention, we did an enormous amount of work with that IRB to try to ensure that everybody was comfortable with us moving forward with this study. Next slide, please. Some things that were very helpful for us, I think one was the study design. Second was making sure that we had a well-engineered intervention. Not surprisingly, leadership support was really key, but perhaps the most important part of this was proactive communications and doing our best to get out in front of this, not only with the staff, but of course with the family members of the patients themselves, and where possible with the patients, to make sure that everybody understood what was being done, they understood the technology, what the potential benefit was, and what concerns we had about safety, so that they felt comfortable about their own safety in that area. Next slide, please. And that ends my comments. I'll turn things back over to Lou. Thank you.
So thank you, Rick. And so I think as folks are now starting to appreciate the complexity of this study, it's important to acknowledge that the study was not conducted. And so could you address that? Why was the study not conducted? and what were major issues?
Yeah, thank you, Lou. Yeah, so we were able to stand the study up, and what really prompted the study being initiated was the 2009 H1N1 pandemic. However, with the widespread use of vaccination by that point, the monovalent vaccine coming out, and then perhaps most importantly, the H1N1 pandemic of 2009 having very lesser impact on our older patient population, particularly those over 50, 60 years of age, compared with our pediatric patients. What we had found over the about 2-year period where the study was run was we had very few outcomes, both in our sham areas and then our germicidal UV treated areas. Way too few outcomes for us to make any meaningful measurements in terms of the effectiveness of ultraviolet light in this setting. And so after a few short years, the pandemic had run its course, and we had decided at that point not to pursue the study any further, because after about 2 years, it was very clear that we were not going to become anywhere close to having the number of outcomes that we would need to, again, make any meaningful measurements.
Thank you. Okay, and I'm gonna open it up here in just a moment. I want to ask one other question using the moderator's prerogative here. So one of the very first questions that was asked of all of you, or any of you, is UV being used for air treatment in your facilities? And if not, why not? And I guess I would add to that, given the evidence that was presented here, not the least of which was the study in the Livermore VA showing a 90% reduction in influenza transmission by serologies. Why isn't this technology being used everywhere?
I can address that if you'd like.
Please.
Well, there are probably many reasons. Basically, UV technology sort of falls between disciplines. Until recently, engineers had relatively little experience with lighting. Folks aren't involved in health issues. And so there were small companies that made upper room fixtures. There were relatively poor guidelines, and the data, as you've seen, is very convincing when you look at it, but it is not abundant. That said, there's not a lot of studies of ventilation and preventing airborne infection either. But nonetheless, this technology is, and the word irradiation, which is why we're using GUV, scares people. There's a lot of fear about the potential harmful effects of, we've been taught since childhood, don't get exposed to sunlight. And the distinction between sunlight, which includes UVA and B that cause skin cancer and cataracts, and UVC, which doesn't, is not widely appreciated. So I think it's a combination of lack of information. People don't understand how effective germicidal UV can be, and that it is safe, and it's been around since the 1930s and shown to be effective. It is being used. During pandemic, we have private schools using it. We have homeless shelters have been using it for decades. It was in prisons. And in other parts of the world, it's widely used in healthcare facilities because of tuberculosis. But not as widely used as you would imagine, given how effective and cost-effective it is.
Thank you. And then one other question before I open it up. So Dr. Martinello, if you were to redo this study, what would you do differently? That includes process issues with conducting the study.
Yeah, I think there's a number of things that we would do differently. Yeah, one is, as Dr. Perencevich alluded to earlier, is I think we would want this to be a multi-site study, recognizing some of the difficulty in ensuring appropriate power to the study, but also recognizing that there's going to be a lot of site-to-site variability in terms of the number of patients and others who may achieve the outcome that the study is measuring. I think the other thing that we learned in the study that we would change is that it did take us a good amount of time to ramp the study up, and much of our early period when we were working on designing the trial was really focused on getting facility leadership involvement, discussion with the IRB to move things forward on that end. And not surprisingly, something that had occurred was word spread in the facility that this study was going to be done. And I think we had allowed a vacuum of information to occur. And so there was a lot of concern that was raised among staff who work there, especially when they learned that it was going to be a random cluster design study. And so it I think took us a lot of effort, having town hall meetings, meeting with many others to try to make up for some of what we had lost by allowing that vacuum of information to occur. And that really, I think, set us back a bit too.
Thank you. Okay, I'll turn to the remaining questions in the chat. It looks like most of them have been addressed. One of the questions is, Rick, did you use a specific brand of UV light?
We did, and I won't mention that brand here, but I'd be happy to talk offline about that if that would be helpful.
Okay, and then there are a couple of questions about messaging on safety, and I think you touched on that. There was also a related question about educational materials. So would you care to expand on what you said earlier about the way that this was messaged and education? And there's also a question about maintenance staff, how were they educated?
Yeah, so a few things very quickly. We did put together a presentation that we presented repeatedly over the course of the study and the development to get the study kicked off. And I think some of the important pieces there were, one, recognizing that there's UVA, B, and C, and that this intervention was really UVC and how that differed from UVA and B. I think the other thing that was very helpful for people to hear was the relative amount of light that they were being exposed to at these different wavelengths, and how that related to, for example, how much UV they would receive during a walk to their car, during a sunny summer day. And so I think making some of those analogies, we found that to be very helpful, very comforting to people. I think the final thing that was really important for us was to have a very active safety program, and having an individual with the appropriate expertise, going in, taking measurements on a weekly basis once we had all the equipment up and running, and also, they're getting to know the people who worked at that facility, so they felt comfortable and had, a trusting relationship with that individual.
Thank you. There is a question here for anyone who would like to respond. Is there any evidence that 222 nanometer UV is as therapeutically effective as 245? I think they mean 254 GUV. Who would like to take that question?
I can address that, Lou. Surprisingly, actually, 222 seems to be more effective. I say that because it is less penetrating, and you would think that it might be less effective in getting at the organisms. But in addition to affecting nucleic acids, it also resonates with proteins. And so there seems to be slightly greater efficacy at 222 than at 254 in the studies that have been done in chambers, et cetera.
Okay, anyone else? Go ahead.
I'll add just a piece to that, Lou, if I can. I think what Ed says is, spot on. But I do think where we're starting to see some differences and where we need some additional information, at least from my perspective, being a NIOSH employee, is as Ed said, 222 is not as penetrating. What happens when these organisms are generated by a human? So they have proteins and salts and everything compacted around the organism. It seems like we can't have it both ways. We can't say that 222 is not penetrating, but yet it can automatically get through all the gunk that may be protecting human generated organisms. So I think that's where we're starting to see some differences when you get outside the lab or you start doing lab tests with, artificial sputums, artificial salivas, these types of things. And I think that's where we need a little bit more information before we have a better handle on truly how effective 222 is compared to 254, because we don't see, at least in some of the studies that I've seen, we don't see that same effect from the gunk at 254 that we're seeing at 222.
I agree with that, Steve. We are planning, we have a proposal in to get funded to do exactly the same setup that we've done for 254 with 222 at 3 different doses with and without ceiling fans. And if that gets funded, we'll be able to make direct comparisons with human generated tuberculosis and infection as an endpoint.
Can I ask a question of both the speakers too? What's the data on ozone production at that 222 wavelength?
So ozone is produced at 222, much more so than at higher wavelengths, but there is data, and there needs to be more data to show that comfort levels of ventilation pretty much mitigate that accumulation. And what dominates, of course, is ozone that's outside, more than what is generated by these lamps. But it is a consideration, something we were not aware of, we are aware of now, and it is a bit of controversy. There are folks who feel that any ozone is unacceptable, and I think we have to take into account that we're also talking about trying to prevent lethal viral infections, particularly in long-term care facilities, and that there's no free lunch with anything, and we need to balance risks and benefits.
Well, thank you. That is a fantastic spot to end the webinar, and I want to thank our presenters for being so gracious with their time and being so informative. And thanks for everyone for joining and hanging on as long as you have for an hour and a half. This is being recorded, and our intention is to post it publicly. So thank you very much once again, and wish you all a great day. Take care.